And so without further ado, I'd like to introduce our moderator, who will also then introduce our speakers for the next session. So we have Dr. Peter Long. He's a workshop planning committee member. He's also the Chief Healthcare Transformation and Affordability Officer at Blue Shield of California and co-chair of the Foresight Project, which is envisioning, testing, and creating a transformed future U.S. health system. So thank you, Peter. We are excited to have you, and I'll leave it to you to introduce the rest of your panel.
Great. Thanks very much, Keisha, and welcome to everyone. It's exciting. I think that was a beautiful framing from Michael and Mai and Keisha about where we stand, and then also grounding it in the human, that this ultimately health, why it's different than many other things that we work on. It's a human condition, and it's all of its complexities. So I think what I will do is we're shifting gears now to talk about this panel. We'll describe successful strategies and what we've learned. So successful and learning strategies of what are the core elements of a scalable integrated financing approach that incentivizes exactly the things that Mai was talking about and what Keisha was saying that those patients, those people need for their health and well-being. So we want to incentivize those positive outcomes for both individuals, those three individuals and others, but also for communities and thinking about at a population level. So I think we've got three terrific speakers here. So what I will do is introduce them now all at once and then ask them to present sequentially. And then we'll have plenty of time for your questions and answers to dig into their experiences, their lessons, and their wisdom for us as we move forward. I'll start with Sharon Lewis, who is a principal at Health Management Associates. She will describe the practical action we can take to accelerate transformation in a strategic fashion with her particular experience on persons with disabilities. She has vast experience both in the public and private sectors at Health and Human Services and the Center for Medicare and Medicaid Services, and is now at Health Management Associates. Then she'll be followed by Dr. Patrick Conway, the CEO of Care Solutions at Optum, who will describe the present achievements. Optum has been at this for quite some time, opportunities and sticking points for payment models, and then give us some of his thoughts about how to accelerate this change and accelerate these payment models. Dr. Conway has experience both at the state and federal level and also as a practicing pediatrician. Then finally, we'll hear from Dr. Piyush Gupta, who is the Chief Health Officer at CityBlock Health, which is a venture-backed approach to provide whole person health for communities. And so he'll describe the potential of innovative models to incentivize change around core behavior and decision-making for and communities. So we've got three terrific panelists. We'll hear their presentations and then come back for questions and answers from the audience. So Sharon, I will turn it to you.
Okay, can you hear me now?
Yes, sounds great.
Okay, great. Thank you. Sorry, initially I missed that. Thank you, Peter. I appreciate the introduction, and thank you to the organizers for this terrific workshop. I appreciate being here. I'm going to dive right in because I know we have a lot that we want to talk about today. But I wanted to start with a bit of level set, just in that as we talk about long-term services and supports, we start with a challenge that I think that may exist less frequently in some of the other areas of healthcare reform and payment reform and value-based payments, in that we really do not have an adequacy in our overall funding sources. Medicaid, as the primary payer for long-term services and supports in the United States, is a program that was never intended to become the backbone of our long-term services and support system, but because of political and economic choices that have been made in the United States, it really is. So I'm going to talk a little bit about that, but that overwhelmingly affects all the other barriers and needs that we have as we start thinking about how we might get to long-term services and supports that actually drive better outcomes, both aligned with the person-centered concepts that Mai talked about, our economic preferences, and the preferences of the individuals that we're serving in our communities. There are really several key elements that are currently standing in our way beyond the base funding issue, and I'll talk a little bit about those and some ways that those levers will come into play in terms of long-term services and supports. Again, the backbone and challenge when we talk about LTSS is that Medicaid is the primary payer. And most people in this country, as I'm sure everyone understands, have very few options. Our private long-term care insurance structure has diminished over time. We have very few people who are participating in long-term care policies, have access to long-term care policies, or that those policies are adequate to meet their needs. And so when we talk about long-term service and supports, we know that Medicaid becomes the only option for many people. And to be clear, when I'm talking about long-term service and supports, I'm talking about people who have support needs in the areas of activities of daily living or instrumental activities of daily living that last for an extended period of time. Not talking about post-acute populations who may be in a rehab facility or in a short-term skilled nursing facility placement. I'm really focused on the populations of individuals for whom we may be talking about a cradle to grave benefit and need. So the math doesn't add up. And without commercial insurance, long-term care insurance, or the ability to cover these costs through Medicare, Medicaid becomes really the only significant pathway for most families and individuals, because most do not have the adequate resources to spend tens of thousands of dollars a year. I think it's also important to note that when we talk about long-term services and supports, we have a very heterogeneous population, and I appreciated the opening comments that we need to remember that we're talking about children, older adults, as well as the adult population across the spectrum of individuals, and including individuals who need and have complex care needs and need long-term services and supports. We also know that by relying upon Medicaid, we are ensuring that we have created an economic factor that can overwhelm a family or an individual because of the needs-based testing. Another critical lever within the long-term service and supports is the workforce, and it is probably, regardless of payment reform or reliance on Medicaid or reliance on a different financing structure, going to be one of the most important factors in driving improvements in care and quality when we're talking about long-term services and supports. Excuse me. So we are at a really important inflection point. And I think that as we're thinking about how we can get to better well-being in a holistic manner, this opportunity that the pandemic has created really is unique in addressing the long-term service and supports needs in this country. There have been multiple efforts over the years at the federal and at the state level to try and address this problem of a financing mechanism and or addressing the broader societal issue of aging and disability needs. COVID-19 brought the challenges of our nursing facilities to the forefront, and we've all seen the impact on that on public interest in long-term services and supports and a better understanding of the options. We also know that we have a system that's not aligned with what people want and need. And the pandemic has given us an opportunity to better understand how we can use home and community-based services in a dispersed manner that allow us to implement remote supports and telehealth, including in areas that had not been explored previously. How do we support individuals who may be receiving a personal care service that relates to supervision or cooking through a telehealth modality? Is that feasible? And those things have been tested during the pandemic. We know that we've expanded some elements of our workforce by allowing family members and legally responsible relatives to become paid caregivers in states that may have not done that previously. We've seen some states dip their toe in the water in terms of expanding self-direction. And we've seen non-traditional providers come in to serve meals, to offer transportation, to support employment needs. We've also learned that we have huge deficits in our technology and communication needs, both at an infrastructure level in terms of our home and community-based delivery system, as well as at an individual level, as these populations became highly dependent, as we all did, on adequate technology for communication. We've also seen the opportunity for care coordinators or case managers, supports coordinators to spend more time working with people virtually and increase the frequency of those check-ins and opportunities for engagement with the individuals. So where does that leave us? What are the levers and what are some examples of how we may move forward to get to a more holistic approach? So I will run through these fairly quickly, knowing that my time is limited, but funding reform. We're seeing some interesting things. Washington State is the first state in the country that has actually implemented a social insurance model in which all Washington residents are paying a small income tax that will start paying benefits in 3 years, and every individual within, once they have vested and paid in for a certain period of time, will have the opportunity to access a long-term care benefit. So it is essentially a social insurance model similar to many of the international models. There are obviously pressures and interests in engaging with Congress and the federal administration on how we could get to a big picture funding reform. And we'll see what proposals have the ability to get to, have the ability to move. I mean, we've tried many times, but there may be opportunity in the COVID environment to begin to address the big picture funding reform so that we can get out of the Medicaid box and stop requiring Medicaid to be the primary payer for long-term services and supports. There are interesting options that have come up through state systems, both public and private, but primarily funded again by Medicaid, related to alternative residential options, including adult family homes or shared living models where individuals and non-professional providers are choosing relationship-based living in a way that allows for some support and supervision, but really addresses that housing need. We know that many individuals who are eligible for aging and disability benefits have a pressure not just around services, but around housing. Additionally, addressing livable communities at the local level, age-friendly cities, and more collaborative approaches to ensuring that individuals can age in place is a critical lever for us as we think about long-term services and supports that can move towards an outcome basis. Technology at both the systemic level and the need for investment in IT infrastructure, data collection, electronic records, the opportunity for our home and community-based service providers to have capacity to even begin to think about quality measurement and the ability to report on things that we might be able to make payment based on. We're still in our infancy in this sector around both the systemic and the individual provider technology needs, as well as consumer technologies. The idea of person-centered is critical to the success of long-term services and supports, and has been central to the construct for many, many years. And within that, the ability to address the needs of multiple populations and hang on to their unique needs. And be aware that when we begin to stratify populations and use data-driven methodologies to begin to try and figure out interventions around individuals, that there are drivers beyond cost and utilization and disease and diagnosis that we need to consider if we're really going to be person-centered in our approaches. Workforce improvements, I touched on that briefly before, but we know that the workforce for LTSS is central. Diversion and rebalancing, moving our systems towards more reliance on home and community-based services and less on nursing facilities and institutional care. The idea of care and supports collaboration and not just coordination, building interdisciplinary teams that include our social service providers in a way that where the playing field is more level and where we're not trying to move social services into a medical model, but we're acknowledging the opportunities and the assets that are there on the ground. And finally, as we think about long-term services and supports levers, we have to think in the context of families. We have to think about families as caregivers. We have to think about families as facilitators of self-determined lives for both children and older adults and people with disabilities of working ages. And they are, at this point, the backbone of our long-term service and support systems. And so we need to be ensuring that we have models and delivery systems that address the person within the context of the family. And I will turn it over to Patrick now.